Hello there, clinical toxicology fans. This video discussion is about thiamine, corresponding to Antidotes in Depth Chapter A27 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to explain why we're even talking about thiamine, a vitamin, in this series of clinical toxicology videos, outline the clinical features of Wernicke-Korsakoff syndrome, and to explain why any controversy might exist regarding in what order thiamine and glucose should be administered to patients when you are treating them empirically for altered mental status. First off, thiamine is a vitamin, and like all vitamins, by definition, serves as a vital cofactor for some aspect of metabolism. If it wasn't necessary, if it wasn't vital in some way, then we wouldn't classify it as a vitamin. Thiamine is vitamin B1, a water-soluble vitamin that acts as a cofactor in energy production. It's a cofactor for the conversion of pyruvate into acetyl coenzyme A, which then enters the tricarboxylic acid cycle, and then it's a cofactor again later in the TCA cycle. The exact biochemical details here aren't important for our current purposes, except to know that you need thiamine for normal metabolism, including glucose/carbohydrate metabolism. There are many potential reasons why a person might have a thiamine deficiency, but the reason we're talking about thiamine deficiency in a series about clinical toxicology is that thiamine deficiency is most classically associated with chronic ethanol consumption. So our threshold for giving thiamine should probably be lower for alcoholic patients. Thiamine deficiency can result in Wernicke encephalopathy, which was first described by this guy, Karl Wernicke, who was a prominent German neuropathologist in the late 19th century. Wernicke encephalopathy consists of three clinical features in the setting of thiamine deficiency. Encephalopathy, some altered mental status and/or memory impairment. Oculomotor dysfunction, altered movement of the eyes, often manifesting as nystagmus. And cerebellar dysfunction, problems with motor coordination that can make a patient ataxic. And while this triad of findings are taught as if you should see them all at once, the full classic triad is seen in only 10 to 17% of patients with Wernicke encephalopathy. To be a little bit more complete about thiamine deficiency, there's another way that thiamine deficiency can present clinically, as the disease beriberi, particularly if it's due to a diet that's consistently thiamine poor, and which was first described in people whose caloric intake was from predominantly polished white rice, and it's the rice polishing process that also removes the thiamine. Patients with beriberi may present with neuropathy and weakness. This form is called dry beriberi, to distinguish it from wet beriberi, where the patient also develops heart failure, with fluid collecting in their lungs and with peripheral edema. Wernicke encephalopathy occurs with thiamine deficiency at a stage where it can be reversible by giving thiamine supplementation. But it may also occur along with Korsakoff syndrome, sometimes called Korsakoff psychosis, which was named after Sergei Korsakoff, a Russian neuropsychiatrist who was also professionally active in the late 19th century. Korsakoff syndrome involves retrograde amnesia, you can't remember things from the past, anterograde amnesia, you can't lay down new memories in your brain, and confabulation, where the patient will make stuff up to fill in the gaps in their memory. And unfortunately, if a patient has gone on to develop Korsakoff syndrome, they've had irreversible damage to their limbic system and memory. It's even possible sometimes to see the brain damage on neuroimaging. The MRI scan here shows injury to the mammillary bodies, which are part of the limbic system, which is involved in memory circuits. Next, we're going to watch a 3-minute video clip from Osmosis about Wernicke-Korsakoff syndrome for a review and summary.
Wernicke-Korsakoff syndrome is a rare neurological condition that causes degeneration of brain cells, or neuronal atrophy. It's caused by thiamine, or vitamin B1 deficiency. Thiamine is a vitamin absorbed in the intestines and used for energy metabolism to support growth, development, and cellular functioning, especially in the brain and nervous system. Thiamine deficiencies are commonly seen with conditions that lead to malnutrition, such as chronic alcohol use. The condition includes two stages: Wernicke encephalopathy, which is the acute and reversible stage, and Korsakoff syndrome, which is when the condition progresses to a chronic and irreversible stage. Now, Wernicke-Korsakoff syndrome commonly presents with the triad of altered mental status, including confusion and memory deficits, nystagmus, or involuntary rapid and repetitive movements of the eyes, and ataxia, or impaired coordination of voluntary movements, balance, and speech. Other symptoms that may develop include agitation, hallucinations, and confabulation, which is when affected individuals create stories they believe to be true to fill gaps in their memory. Diagnosis of Wernicke-Korsakoff syndrome is typically based on the individual's history and physical examination. Laboratory tests like a complete blood count, liver function tests, and thiamine levels are also commonly done. In some cases, diagnosis may be confirmed with an MRI of the brain showing degeneration of the mammillary bodies, which are two areas in the brain responsible for memory. Now, the treatment for Wernicke encephalopathy is to consider it a medical emergency, and it must be addressed immediately to prevent the development of Korsakoff syndrome. Treatment involves intravenous thiamine administration as soon as there is clinical suspicion of Wernicke-Korsakoff syndrome. If Wernicke encephalopathy is treated promptly, affected individuals can begin to improve within 2 to 3 weeks of treatment. However, if Wernicke encephalopathy progressive to Korsakoff syndrome, affected individuals may require lifelong treatments that include oral thiamine and rehabilitation. Alright, as a quick recap. Wernicke-Korsakoff syndrome is a rare neurological condition that causes neuronal atrophy due to thiamine or vitamin B1 deficiency, and is commonly seen in chronic alcoholism. It consists of a classic triad of altered mental status, nystagmus, and ataxia. Diagnosis is usually based on clinical evaluation. Lastly, treatment involves the prompt administration of thiamine, addressing any underlying cause, and long-term care as needed.
And with regard to the last learning objective, imagine you're seeing a patient, probably in the emergency department, who arrives with altered mental status. And for whatever reason, we have some suspicion this patient has a history of chronic alcohol use. There's several reasons the patient could be altered. They could be intoxicated with alcohol. They could be hypoglycemic, which is associated with alcohol, but it's something you should suspect in any altered patient until or unless you can prove otherwise. If they're a chronic alcoholic, the altered mental status could be Wernicke encephalopathy, or they could have head trauma or any number of other things going on. We'd like to treat those things that might be reversible, like hypoglycemia by giving glucose, or Wernicke encephalopathy by giving thiamine. And this has led to some controversy, where it used to be taught that you should give thiamine first. But why? The reasoning is that if you were to give glucose first in a thiamine-deficient patient, metabolizing that carbohydrate load causes further stress on the tenuously fragile system, and you'd precipitate Wernicke's in a patient who didn't have it yet, or worsen Wernicke's in a patient who had it already. The argument to give glucose first is that a first dose of glucose, to reverse potential hypoglycemia, probably isn't enough to induce or worsen Wernicke's anyway. But even if it was true that the order actually mattered, the uptake of thiamine is slower than glucose, such that giving thiamine immediately and then waiting a little bit before then giving glucose is just subjecting the patient to the risks of hypoglycemia for a longer time without any likely benefit. So the current recommendations, if you're going to give thiamine and glucose empirically to treat altered mental status, you give the glucose first because hypoglycemia is bad. And now finally to dosing. If you're giving thiamine empirically due to concern for potential Wernicke encephalopathy, and this is going to happen frequently in the emergency department, the dose is 100 milligrams parenterally, which almost always means IV. And for follow-up dosing, if you're treating known or presumed Wernicke encephalopathy, there's a wide range of doses that have been recommended in the literature, but they are all with daily dosing of at least 100 milligrams. That's it for now about thiamine as an antidote. I'll be seeing you around.